Hello, this is Barb Norquist. I'm a gynecologic oncologist at the University of Washington in Seattle, Washington. And there I take care of patients both with ovarian cancer and at increased genetic risk for it. And so I'm very pleased to present to this group an update on what is new in gynecologic cancer screening and prevention. I have no financial disclosures. This is a brief overview of the topics we're going to cover. First, just the basics of gynecologic cancer prevention as it pertains to those with inherited risk, what we know and what we don't know about ovarian cancer screening, and then the experimental strategy of interval salpingectomy with delayed oophorectomy. So first, just the basics of gynecologic cancer prevention for those at risk. So why are some patients at increased risk of gynecologic cancer? One is due to inherited mutations in the BRCA1 and BRCA2 genes. And these are the syndromes that we have kind of the most information about, the largest amount of accumulated knowledge to help us know what to do. There are also several genes in which inherited mutations are associated with an increased risk of endometrial cancer or cancers in the lining of the uterus. And that is from a syndrome called Lynch syndrome with the genes MLH1, MSH2, MSH6, and PMS2. And then also Cowden syndrome with mutations in PTEN. And also inherited mutations in other genes are associated with ovarian cancer risk, such as RAD51C, RAD51D, BRIP1, and PALB2. These are more recently discovered than the BRCA1 and 2 genes. So we have a bit less data, but how to help patients with these inherited mutations has become increasingly clear over the past decade or so. We also occasionally encounter patients with a very strong family history of ovarian cancer, but we're unable to identify the genetic cause of cancer risk in the family. And so sometimes on a case-by-case basis, we will offer these patients prevention strategies as well. So what are the risks of developing breast and ovarian cancer with BRCA1 and 2 mutations? And this is from an excellent paper that followed people over time with these inherited mutations to better quantify the risks of breast and ovarian cancer. You can see the breast cancer risk there on the left, and then on the right side of the graph is the ovarian cancer risk. And there's a different line for BRCA1 versus BRCA2 carriers. Patients with BRCA1 mutations have a higher risk of developing ovarian cancer, and also the risk starts to go up at a younger age than it does with BRCA2. The reasons that we pay attention to this is it informs our recommendations for timing of risk-reducing surgery, because we want to make sure that we have a chance to intervene prior to the age at which a person could develop that cancer. This is a table showing the lifetime cancer risks associated with Lynch syndrome. You can see that the different genes that make up Lynch syndrome actually have different risks associated with them. And so we need to split these data rather than lump. So you can see the risks for colorectal cancer, which are quite high, endometrial cancer, which is highest for MLH1, MSH2, and MSH6. And then finally, ovarian cancer risk, which is elevated in MLH1 and MSH2, probably elevated, but to a lesser degree in MSH6. And then with PMS2, likely no increased risk over the population. So what steps can be taken to reduce gynecologic cancer risk? So first is just understanding the causes. I truly believe that knowledge is power. Understanding the risk, particularly with inherited syndromes, understanding appropriate timing for interventions, and making connections with a team that can help you is the most important thing. We know that medications such as oral contraceptive pills or birth control pills can reduce the risks of both ovarian and endometrial cancer. And finally, surgery is really the gold standard for prevention of ovarian and fallopian tube cancer. And I'll spend some more time talking about that. And then also important is awareness of the common symptoms of gynecologic cancer. So ovarian cancer, the most commonly described symptoms are persistent bloating, abdominal or pelvic pain, urinary frequency, and getting full quickly. Any of us can have these symptoms on a transient basis, for short periods of time, related to a variety of things. But what's different about patients with ovarian cancer is these symptoms persist and they get worse over time. Recognition of endometrial cancer in a patient prior to menopause who's still menstruating, changes in the bleeding pattern or bleeding in between periods can be an indicator that a person might need an evaluation. And in a patient who is past menopause, which means, usually somewhere around age 50 or so, they have ceased having menstrual periods for a year. Development of any bleeding of any quantity after that time should be investigated because that can be a symptom of endometrial cancer. I'm going to define some of the terms that we will use while discussing risk-reducing surgery. So this is just a diagram of female pelvic anatomy with a uterus and cervix, which is kind of one unit there, the attached fallopian tubes and ovaries, and then the vagina. So BSO stands for bilateral salpingo-oophorectomy, or removal of the fallopian tubes and ovaries, which is usually what I write on my consent forms. Risk-reducing salpingo-oophorectomy is another term that gets used a lot, or you'll see RRSO, which is what that stands for. Salpingectomy refers to removal of just the fallopian tubes. And the fallopian tubes are just the conduit between the uterus and the ovary without any hormonal impact. The term hysterectomy applies to removal of the uterus. In most cases, we will remove the cervix along with the uterus if that is desired, because it's essentially one organ, but there are some options to retain the cervix as well, but that's of limited clinical benefit. The surgical approach of choice for risk reduction surgery, particularly for ovarian cancer prevention, is laparoscopy. This is a surgical method through multiple small incisions, also called minimally invasive surgery, where you can make a small hole for a camera to be able to see the abdomen, and then other small places to insert ports for instruments to do the surgery. What this method allows for is you can get a good survey of the entire abdominal cavity by just moving the laparoscope around. Ovarian cancers tend to involve the peritoneal cavity, and so that is what we like to look at. You can also see the entire blood supply to the ovary and be able to remove it completely. A laparotomy refers to surgery through a single larger incision, sometimes called open surgery. This is kind of a C-section style cut or a fan steel incision or a vertical midline incision. This is almost never indicated in the setting of risk reduction surgery. And so if this is the method that is proposed, some questions should be asked about that. There's always exceptions to all of these rules, but laparoscopy or robotics is kind of the gold standard to allow for this abdominal assessment and to reduce the risk of complications and to shorten the recovery time. Vaginal surgeries, vaginal hysterectomy is an excellent procedure just to remove the uterus, but it's a lot harder to see the ovaries adequately and to remove the ovarian blood supply. And this also keeps you from being able to do the abdominal survey with the camera to look around the inside of the abdomen. So vaginal surgery is also typically not the recommended method for risk-reducing surgery. And what do our guidelines say for surgical prevention in BRCA1 and 2 mutation carriers who do not have cancer? So risk-reducing salpingo-oophorectomy or removal of the tubes and ovaries is recommended between the ages of 35 to 40 for BRCA1 carriers and between the ages of 40 to 45 for BRCA2 carriers. And I don't know if you recall in that first slide where we showed the risks of ovarian cancer, you could see that the curve started to go up at a younger age for BRCA1 carriers. And that's why the guidelines are different by age for these two groups. BRCA1 and BRCA2 are proteins that are involved in a complex. You know, they work together with other proteins to help repair DNA. And so we've learned over the past decade that several other genes in this pathway that work together with BRCA1 and 2, when these genes are altered by inherited mutations, they can also cause an increased risk of ovarian cancer, much like BRCA1 and BRCA2 does. BRIP1, RAD51D, and RAD51C are genes that, again, were discovered kind of in the 2010, 2011 range, and then eventually have been incorporated into the NCCN guidelines. As of 2022 guidelines, the language used was to consider risk-reducing salpingo-oophorectomy between 45 to 50 for patients with inherited mutations in these genes. And then in the most recent version of the guidelines, this was upgraded to recommend rather than consider. And that may not sound like much, but this is an incremental change in the guidelines to actually formally recommend this intervention. Another gene that I mentioned earlier is called PALB2, which stands for partner and localizer of BRCA2. We know that PALB2 is very important for breast cancer risk, but it also contributes to ovarian cancer risk. And there have been a number of studies. These are two more recent ones. One was a study of multiple families impacted by PALB2, and the other is what was called a case control study, where they looked to see if the frequency of PALB2 mutations is higher in patients with ovarian cancer than in control populations. Based on these two studies, it's estimated that the risk of ovarian cancer with PALB2 is somewhere between 3 to 5%, compared to the population risk of about 1.5%. There are clinical guidelines for management of PALB2. The ACMG in 2021 published a paper with guidelines for PALB2 mutation carriers that described considering risk-reducing salpingo-oophorectomy with non-directive counseling at or beyond menopause. The primary harm of removing the ovaries is premature surgical menopause. And so the closer to menopause that we do that intervention, the less harm that we cause. NCCN in 2023 added the option to consider risk-reducing salpingo-oophorectomy either at or later than the age of 45. Which is a change to the past guidelines, which previously stated there was insufficient evidence for risk-reducing salpingo-oophorectomy. So this change in the guidelines here is really important to note, and patients with PALB2 should speak to an expert as they are available to discuss that option of risk-reducing surgery. Is removal of the tubes and ovaries effective for preventing ovarian and fallopian tube cancer? And essentially, yes, it's incredibly effective. Removing that at-risk tissue takes the risk as close to zero as we can make it. There is still a residual risk of cancer cells growing within the peritoneal cavity that may have been previously shed by the fallopian tube or an ovary. We estimate that that risk is somewhere around 1 to 2% after the tubes and ovaries are removed. So low, but not zero. But in general, this is an incredibly successful intervention to reduce death from ovarian cancer. Another fork in the road when patients are planning removal of the tubes and ovaries for ovarian cancer risk reduction is whether or not to remove the uterus as well. There are a number of pros and cons to hysterectomy at the time of risk-reducing surgery. And this is typically a pretty involved conversation that I have with my patients in this scenario. Potential benefits to hysterectomy is that hormone replacement therapy is simpler and easier and potentially safer without a uterus present, because the uterus is the only organ in the body that needs progesterone along with estrogen. Estrogen is the main medication that helps with managing menopausal symptoms, maintaining bone density, promoting cardiovascular health, all the other benefits of estrogen. And estrogen and progesterone together were shown in the Women's Health Initiative study to increase the risk of breast cancer, but estrogen alone did not. And so if you don't have a uterus, you can take estrogen alone, potentially have less side effects and potentially a lower risk of breast cancer. If a person is having problems with their uterus, then that's an opportunity to have it removed. And there are some studies showing a possible small increased risk of endometrial cancer, particularly with BRCA1 carriers. This risk is not high, but it is present. And so for some patients, they really want to maximize any and all risk reduction that they can do. Potential cons of hysterectomy, which are very real, are an increased risk of having a complication, a longer recovery time from surgery, so more time off from work and other activities that are essential to quality of life and well-being, and it's unlikely to impact the ovarian cancer risk. Also, some patients are not done with childbearing, and so if they wish to carry a pregnancy, they would have to still maintain a uterus. So this is definitely in the category of optional, and a thorough risk-benefit discussion should be had with each patient before making this decision. I would be wary of providers who put this in very absolute terms and say that they always do a hysterectomy or never do a hysterectomy, because again, it's a lot more complicated than that. And this is the study I mentioned showing that BRCA1 carriers may have an increased risk of high-grade endometrial cancer with a lifetime risk estimated somewhere around 2 to 4%. This is residual risk after BSO. So an overview of just some principles of risk reduction surgery. While we're reducing risk, we want to make sure we're not taking any extra risk, if that makes any sense. And this is kind of the same idea behind doing laparoscopy or a more minimally invasive surgery rather than an open procedure, so that we're minimizing the risk. The minimal procedure is assessment of the abdomen, collection of pelvic washings, and removal of the ovaries and fallopian tubes. A very important aspect of this surgery is the preoperative counseling about the hormonal impact of removing the ovaries and how this is going to be managed. A plan for this needs to be made prior to surgery so that people are not surprised. Our patients who have had particularly estrogen receptor positive breast cancer in the past are typically, it is not safe to give them hormone replacement therapy. And so they have to understand the impact of the surgery on their both symptoms and health complications. So is hormone replacement therapy recommended for premenopausal mutation carriers after risk-reducing surgery if they do not have a personal history of breast cancer? Here's what the guidelines say. NCCN says discuss possible short-term hormone replacement therapy, which is pretty vague, and I think that statement could be stronger. The North American Menopause Society states, on the basis of limited observational studies, consider offering systemic hormone therapy until the median age of menopause, around age 52. And ACOG, the American College of Obstetricians and Gynecologists, state that women who are unaffected by breast cancer should be offered hormone replacement therapy to mitigate the effects of early menopause. The reason I'm spending so much time discussing this is that a lot of medical providers and patients have been told or believe that taking estrogen therapy is not allowed if you have a BRCA1 or 2 mutation, and that just isn't true. Other considerations, pathology is really important. This figure is a drawing of a fallopian tube with these multiple sections cut through it. This is what happens in the hospital after the fallopian tube gets removed. The pathology staff will cut it into pieces to make slides. And historically, just 1 or 2 sections was deemed adequate to evaluate a normal-looking fallopian tube. But we know that in patients with genetic risk of ovarian cancer, that they can have microscopic lesions in the fallopian tube. And so they have to use a specific protocol in order to correctly evaluate it. And so that's another question to ask when speaking with a provider about risk reduction surgery. We like to enroll our patients in research studies. It's helpful if the surgeon understands the underlying genetics. There's oftentimes some difficulty with interpreting genetic test reports, and sometimes action is taken erroneously based on an incomplete understanding of the report. And it's helpful to be in a center where there's expertise to handle malignancy if it's encountered, meaning if we find cancer at the time of surgery. So what about ovarian cancer screening? What do we know and what do we not know? So the primary scope of the problem is that most what we call ovarian cancers start in the fallopian tube. And this is a really high power view of an early invasive fallopian tube cancer. The type of testing that we have right now for ovarian cancer screening with pelvic ultrasound and blood test monitoring for CA125, like we can't find this type of lesion with those tests. Ideally, a screening test should be able to identify a precursor to cancer that can be successfully treated. And the best we can hope for with ovarian cancer at this point is early detection because the precursors are not detectable. And most of us in this field would consider failing to prevent the ovarian cancer as an unacceptable outcome. And again, here's our current methods: CA125 blood test monitoring and a transvaginal pelvic ultrasound. These are very useful tests in evaluating anyone with pelvic symptoms who's at increased risk of cancer. So pelvic pain, change in bleeding, other issues. So ultrasound's really our go-to test to work that up. But we don't necessarily have proof that doing this monitoring in the absence of symptoms is beneficial or helps patients who develop ovarian cancer live longer. There have been a couple of large studies just in the general population, so not people known to be at risk of ovarian cancer, but just the general population, looking at ovarian cancer screening, and essentially found no difference in death from ovarian cancer based on this strategy. There was a clinical trial looking at high-risk patients, so patients who were deemed to have a greater than or equal to 10% lifetime risk of ovarian cancer. So all of our mutation carriers would be in this group. They did a CA125 every 4 months and a transvaginal ultrasound if any of that testing was abnormal. And in that study, they felt as though more than expected number of cases were earlier stage. So perhaps this can help detect easier to treat cancers. But again, prevention is our goal. So should anyone get ovarian cancer screening? In normal risk patients, this is given a grade of D by the U.S. Preventative Task Force with fair evidence to exclude from periodic health exams because the screening test can actually lead to unnecessary surgeries and complications. For patients at increased risk, NCCN most recently said that ultrasound and serum CA125 for ovarian cancer screening, although of uncertain benefit, may be considered at the clinician's discretion starting at age 30 to 35. And actually, in the most recent version of the NCCN guidelines, this point was removed. So the NCCN now has no kind of official stance on screening because of the issues with it not being effective. That being said, I get these tests prior to surgery because I don't like surprises. I'd rather be able to have a conversation with the patient if there's anything abnormal. And I do think it can function as a bridge to surgery because we are getting more data. We just don't know how much we can rely upon it. And it is not the gold standard, which is surgery. So again, we can't find the precursors. Hopefully we're going to have molecular methods soon with some kind of blood test or pap test or some kind of sample collected where we can try to find an indicator of this early disease or a precursor. I don't mean to sound negative about the concept of screening in general, because for other cancers, screening is incredibly effective. For colon cancer, when you have a colonoscopy, they can find polyps that can be removed before they become malignant and effectively prevent the cancer. In cervical cancer, pap smears work incredibly well at detecting abnormal cells that can then be treated before they become a malignancy. And with breast cancer, we know that early detection from mammography and MRI have really meaningful impacts on survival and how easy or difficult the treatment of the breast cancer is. So please know that screening for other diseases is very effective. So I'm going to end with a discussion of this new strategy of interval salpingectomy with delayed oophorectomy. So many patients have reasons they wish to delay removal of their ovaries. We know that removing the ovaries prior to menopause can increase all-cause mortality just when you look at the general population. We can mitigate many consequences of surgical menopause with hormone replacement therapy, but not all of them. There are multiple factors to consider. If a patient's done with childbearing, which gene is mutated, meaning like at what age does this person really become at higher risk? And are there any signals in the family history that might lead us to consider different timing? This is predicated on the idea of the tubal hypothesis, which is that the majority of serous ovarian and peritoneal carcinomas are actually seeded from cancer cells from the fallopian tube epithelium. And so we do think that many, if not most, of these cancers really start in the tube. So can we just take out the tube? Potential benefits to that strategy is we know it should reduce the risk of ovarian cancer. The main con is that the degree of risk reduction, we can't actually estimate it right now because we don't have long-term data on this strategy. Other benefits include maintaining normal hormone function because the fallopian tube has no role in hormones. It is just a conduit to get the egg and the sperm together. Removal of the fallopian tubes, by that same token, is a sterilization procedure, which is either a pro or a con, depending on where a person's at in their life. And we still recommend removal of the ovaries if a person's had a salpingectomy. And so that requires 2 surgeries instead of 1. Part of what gives us pause is we don't know exactly when those cells might transfer from the fallopian tube epithelium to the ovary. And this is just a high power view, a little piece of fallopian tube epithelium sitting on the surface of the ovary. So, if this has already happened and then you take out the fallopian tube, you may not be removing all of the risk. So we've had a couple of clinical trials looking at this strategy. This first study was called WISP, Women Choosing Surgical Prevention, and was open at multiple centers across the US. This was open to patients between the ages of 30 to 50 who had mutations in BRCA1 and 2 and other ovarian cancer risk genes. And then the patient and the surgeon together made a decision about the surgical plan. This was not randomized because that would not be an ethical way to run this type of trial. The primary outcome in this study was sexual function, and secondary outcomes were vasomotor symptoms, psychological symptoms, and then pathologic results, meaning how often did we find a cancer or a precancer as part of these surgeries. At the same time, the WISP trial was being undertaken. The Dutch TUBA study was going on with a very similar structure to WISP. And both investigators presented their findings at the same meeting and were able to pool some of their data together to make this slide, indicating that in each study, no matter what strategy was employed, patients felt decreased cancer worry and lower distress. There was less decisional regret in the patients who had a self-injectomy first, fewer menopausal symptoms, and improved quality of life. The sexual function data is still pending, but does appear to be better as well in this group. Both studies had a stopping rule, indicating that if cancers were happening in patients waiting on oophorectomy, that the study would be shut down. Neither study had that outcome. But in terms of the efficacy to reduce cancer, neither of these studies was powered to look at that, meaning there were not enough patients in the study to see how effective it was. These studies really just dealt with quality of life. So to answer that question, we have two studies pending. One is called SOROC, which is open at 318 sites. Similar to WISP and TUBA, it's not randomized. The patient and their physician decide if they're having both tubes and ovaries removed or the fallopian tubes first, with a plan to remove the ovaries later. And this study is restricted to patients who are between the ages of 35 to 50. This study is going to take, at least a decade to have any results. TUBA WISP 2 is a continuation of both the TUBA and WISP studies that were mentioned before. This study enrolls a slightly wider population, kind of including other genes like BRCA2, BRCA1, RAD51C, and RAD51D, and allows for younger ages. It's currently open in the Netherlands and at MD Anderson, and then other sites will be opening soon, including UW in Seattle. In Canada, particularly British Columbia, they've really led the way on removing fallopian tubes whenever they can, and then looking at the impact of that on rates of ovarian cancer in their population. So they looked back at 60,000 Canadian patients who either had tubal ligation, so just occlusion of a part of the fallopian tube, or a hysterectomy, versus those who had the entire fallopian tube removed. And they were able to show that population-wide, there were fewer epithelial ovarian cancers than they expected in the group that had had their fallopian tubes removed. As a control check, they also looked at incidence of breast cancer and colorectal cancer, and there was no difference between the two groups, showing that they didn't have a bias in who was in each group. I would say it's biologically plausible that the younger a person is having their fallopian tubes removed, probably the more effective it might be to prevent ovarian cancer, but childbearing concerns are what would keep someone from doing that. All right, so final take-home points. The mainstay of gynecologic cancer prevention is surgery. That is really the most effective. This is for hereditary risk. I didn't mention cervical cancer at all because it is not part of inherited syndromes, but prevention of cervical cancer is done through HPV vaccination, and pap smears. And those strategies work incredibly well for cervical cancer. But for the inherited gynecologic cancers, really surgery is our most effective strategy. Surgery should be minimally invasive and appropriately timed, not too young, not too old, based on that individual patient's needs and circumstances. Interval salpingectomy with delayed oophorectomy is being explored in clinical trials. And even not in clinical trials, we are offering this clinically to patients, particularly if they're planning their oophorectomies still within the guideline recommended ages. And finally, ovarian cancer screening with ultrasound and CA-125 blood tests is not terribly effective and is not a substitute for the life-saving surgery. So I believe that concludes my presentation. I thank you for your time and attention, and I hope that this is helpful. Thanks, bye.